Before we kick off today's event and I introduce our amazing facilitator, just a few housekeeping items. This training is short and sweet and interactive. You'll be breaking into dyads to chat with each other. You'll be doing role-playing exercises, and you're ultimately going to use this space to learn and to practice. So for that reason, we would really encourage all of you to turn on your screen and close that email box as much as you're able. We know that many of you may be working from home or in other unique circumstances. So if your kid or your dog or your neighbor pops in, that is a-okay. We will wave, and we will certainly understand if you need a minute to deal with an emergency. There is no shame in the remote working game here. I have little ones running around at my house, and they may make an appearance, and just so be it. And finally, take care of yourself in this meeting. Drink water, eat lunch, stand up and stretch. Our days are packed, and we need to practice what we preach and show ourselves empathy and care, just as we do those around us. I'll be monitoring the chat, so if you have any questions, please go ahead and pop them in there, and I'll bring them out to our facilitator to share with all of you. So with that, are there any questions before I introduce our fantastic facilitator? Okay. Dr. Deirdre Bernard-Pearl is a pediatrician and innovator who believes in equity and healing. She's a graduate of the Stanford University School of Medicine and completed her internship and residency at the Children's Hospital of Oakland. She recently deepened her leadership journey as a fellow in the UCSF California Healthcare Foundation Clinical Leadership Fellowship. Dr. Pearl is the medical director of pediatrics at Santa Rosa Community Health, where ACEs screening and trauma-informed care were introduced in 2014. She serves on the California Office of the Surgeon General's ACEs Aware Clinical Implementation Subcommittee. Dr. Pearl, take it away.
Thank you so much, Erin, for the introduction and for this opportunity. We did start our ACEs screening journey back in 2014. We've screened over 15,000 patients, and we've learned a little about how to do it in a sensitive and empathic way, and that's what I'm hoping to share with you all during our time together. Just for myself, my pronouns, she, her, hers. Always important, I think, to acknowledge the land that we live and work on. And I'd like very much to find out a little bit about all of you and who's here today. And I think we may have a little poll set up. Erin, are you able to activate the poll?
Launching it right now.
Okay, great. So just on the screen, if you can choose, there are 3 questions.
So are you able to all see the results as they pop up, or do I need to?
Yes.
Okay, great.
It is live.
Great.
Okay, that's great. Thank you so much for doing that. Interesting. So we can see we have 31% mental health clinicians, still some answers coming in. Oh, 70% others. So I guess I'd like to find out, maybe just type in the chat, who else is here that I didn't realize may be signing up? And you're all welcome. It's helpful to know who's here. Screening in your practice looks like 36% yes, 43% no, 21% planning to. Favorite vacation? Oh, good. Look at that. Beach, 57%, snow, only 7%. And what's a vacation? It's been so long, I've forgotten, 36%. That's great. Thank you very much for answering all of that. I'm going to, let's see, I think I need to open my chat to see who else is here. Oh, fantastic. So we have someone, a social worker, public health, community health worker manager, development for Hannah, Dovetail, wonderful, family resource center, project specialist, ACSW, wonderful. Well, thank you so much for coming. And that's really helpful to know all the different job roles and agencies that you're with, and that will help me try to make the presentation as applicable to what you do as possible. So before we launch into the content today and some of the practicing exercises that I've planned, I thought it might be helpful to do a grounding exercise. I try in as many of my meetings as trainings as possible to build in just a very short mindfulness moment, 1 or 2 minutes, that is very helpful for me to get more grounded and present for whatever the work is. Even if it's a business-oriented meeting, I find meetings to be more productive if we just take a couple minutes to ground at the beginning and kind of get the stresses and work of the day cleared for the moment, for the time together. And certainly if we're involved in any stressful clinical work, it can be helpful. So both as an exercise and a practice to make this training more useful, and also I hope to model, if you don't this, how really simple it can be to take the time together. So I have an image of just water. Many people find water to be a healing image. I like to set a timer because that way I can keep track, and 2 minutes of quiet time together is often enough to experience some benefit, and it doesn't really cut into meeting times. What's 2 minutes, right? So with that, I would like to invite you to participate in whatever way you choose. You may find it helpful to close your eyes, or you may feel better having your eyes open. You may find it helpful to find a comfortable position to be seated in. Often having feet firmly on the ground can be part of physical grounding. And the prompt is to sit and think about something or someone for whom or for which you feel some sense of gratitude. So I'm going to start the 2 minutes now. I'm going to close my eyes as well, and we'll be back together in just 2 minutes. Okay, that's 2 minutes. I'll bring you back. Open your eyes if you would, if they were closed. And I'll just share that what came to mind when I thought a little bit about gratitude, once I got a little more grounded, was that I'm actually really grateful to be working in a region that has so many agencies and services and supports for families. It's pretty extraordinary what Sonoma County and Marin and some of the other northern counties do and aim to do to support families and really be very trauma informed in their approaches. And I feel gratitude for that. If you'd like to share anything that came to mind for you, I welcome you to use the chat as much or as little as you like. Some people really like that interaction. Others I know prefer to just focus on speakers and slides and those sorts of things. So that's really there for you to use and share if you'd like to. So now launching in, the goal for the presentation. The goal is to enhance our skills in effectively conveying empathy to others. And I initially included specifically when responding to ACEs screening, but now that I understand that many people who came to this may not be doing ACEs screening specifically, just to reassure, empathy skills are fantastic life skills. They're fantastic for any work with coworkers, with clients in any particular way. So I hope that the training and the skills will be applicable whether or not you're a clinician doing ACEs screening in that environment. The overview for the presentation and workshop today is first starting with a little bit of ACEs background, just in case some people here today may not be very familiar with definitions and implications of ACEs and what that means. I'll be sharing with you something called the triads framework. We'll move into understanding empathy and then the skill building around verbal and nonverbal empathy related skills. And most important, and not to be an afterthought, but really very much centering the issue of self-compassion in this work. And I hope the grounding exercise that we did was a little flavor of how we can all take care of ourselves as part of doing our work and sustaining ourselves. So moving directly into the ACEs screening and response background and the context. So fortunately for me, PBS NewsHour, which does so much great programming, did a really nice 3-part miniseries just this past December. They profiled, here's Dr. Nadine Burke-Harris, California Surgeon General, who's really been such an innovator and change maker in this space. She'll be talking a little bit about the ACEs screening framework and opportunity, and then it moves into a very short example of ACEs screening in a clinic by another innovator, Dr. Dana Long, a pediatric colleague of mine who works at Benioff Oakland Children's Hospital, and she's one of the creators of what's called the PEARLS tool, which is the pediatric ACEs screening tool, with one of the families she sees in her clinic, talking a little bit about screening. So with that, I'll share this clip. If you have any technical problems, please use the chat right away, so we'll be alerted to any issues.
Fall in love all over again with star-crossed lovers.
She's a Capulet.
Oh.
His name is Romeo.
You have to watch
Romeo and Juliet, an original film from National Theatre.
When Romeo is found, that hour is his last.
I want to watch.
Can I go forward when my heart is here?
Look for Romeo and Juliet on Great Performances.
Please try to do so. That is where so much healing can occur, is in the telling of our stories.
This is treatable.
For Dr. Nadine Burke-Harris, that's the key takeaway.
What the science shows is that it's never too late to actually begin healing from the effects of early adversity. Number two, what the research shows that although it's never too late, early detection and early intervention dramatically improves outcomes.
With that in mind, late last year, California launched an initiative to train medical providers on how to screen for adverse childhood experiences. And those screenings are now covered under Medi-Cal, the state's Medicaid program. Aisha James and her family have benefited from the growing understanding of ACEs and their health impact.
I'm so glad to see you guys.
Her son's pediatrician is Dr. Dana Long at UCSF Benioff Children's Hospital in Oakland.
It is a piece of information that allows me to help guide and shape a treatment plan with an understanding that this kid is experiencing a lot, and it is traumatic, and it's influencing them on a biologic level, so that we can actually get to a place of healing.
And they're not just relying on traditional medical interventions. She and a team of colleagues connect families in need with resources like food, school interventions, and therapy. And they coach them on stress relief techniques like meditation and breathing.
We can't make the stress go away, but they are able to regulate the stress through techniques and tools.
Aisha has worked hard to incorporate these new tools into her family's day-to-day life.
It just opened all of us up to a different way of how to deal with things before just getting into them verbally, combatively, beating our head up against a brick wall, slamming doors.
And while life isn't perfect, things have gotten better. The boys' asthma is under control, they're having fewer issues in school, and they're also able to better manage their stress, which, in times like this, means everything. For the PBS NewsHour, I'm Kat Wise in the Bay Area.
There we go. Well, I hope that was a helpful introduction to the ACEs screening context. So what exactly are adverse childhood experiences? So the term comes from a landmark study in 1998 by Drs. Felitti and Anda. Felitti from Kaiser Permanente and Anda from the CDC. They described 10 categories of adversities experienced during childhood before the age of 18. And they fall into 3 specific categories: abuse, which includes physical, emotional, and sexual abuse; neglect, physical and emotional; and what was originally called household dysfunction and has now been renamed household challenges, which is everything from growing up in a household where someone is incarcerated, where someone has a serious mental illness, substance dependence, or an adult is absent due to separation or divorce. And it also includes exposure to intimate partner violence. This is another way to visualize and categorize the 10 categories of ACEs, or adverse childhood experiences. I'd like to show you, I know that the tool is probably too small to read easily, but this is what's referred to as the PEARLS child screener. There's a teen version as well. And what I wanted to point out is that part 1 of the PEARLS tool has what are the original 10 ACEs questions, one for each of the 10 ACE categories that we just discussed. And then part 2 on the second page includes additional adversities that may be risk factors for toxic stress as well. So the idea is that if you're exposed to adverse childhood experiences that may or may not create the situation for you, what is called toxic stress, which leads to poor health outcomes. And the original 10 ACEs described in that landmark study have been expanded to include other forms of adversity, whether it's community trauma, discrimination, racism, other kinds of very serious adversities that many people are exposed to. And they're not included in part 1 of the questionnaire because we just have more data as a scientific tool on those first 10, But the fact that the Pearls included this second part with the broader definitions of trauma, I think shows a recognition of how impactful things like racism actually are on health. The prevalence of ACEs in California. So on the left, we can see a breakdown. Orange shows the percentage of Californians surveyed who've experienced at least one ACE. So you can see they're common. Roughly 2/3 of people in California have experienced at least one ACE. And on the right, you can see that 16% have experienced 4 or more ACEs. And then what's very important to understand about ACEs and health is that having ACEs dramatically increases the risk of at least 9 of the 10 leading causes of death in the United States. So if you're a data and statistics and numbers person, you may be familiar with what's called an odds ratio. So that means for someone who has a score of 4 or more, the odds that they will have heart disease is 2.1, or more than double the odds of someone who does not have 4 or more ACEs. And if you look at this list, some of them might be more surprising than others. So it's also a factor of 2 in terms of risk of stroke. Alzheimer's or dementia, odds ratio of 11 means 11 times the risk. And you could wonder, well, how is that possible? How does child ACEs impact the risk of all of these things, and what's the common thread? Well, the mechanism biologically, we think, has everything to do with diseases that are moderated by inflammation in the body. And now we know a lot more about how that works and how stress and unbuffered toxic stress through ACEs can put you at risk for all of these things. And then it's hard to look at this slide and not notice that for suicide attempts, the odds of a suicide attempt for someone with 4 or more ACEs is 37 times that of the rest of the population. So these are enormous, statistically significant impacts. And the science behind all of this is the reason why California is embracing ACEs screening as a very important health crisis, and something that we really believe and hope we can impact and heal and ideally prevent in the next generation. So, what are considered best practices in terms of finding out about someone's ACEs and how to respond? There's a group at UCSF, including a really wonderful researcher and child psychologist who specialized in treatments for child abuse for many years by the name of Dr. Alicia Lieberman. And they created this framework. It's called Triads, and it stands for Triad of Adversity, Distress, and Strengths. And so I find it a really useful framework for thinking about when I hear about trauma, whether it's through an ACE or Pearl screen or some other disclosure, what's the most important thing that I can do as a professional to help the person who's made this disclosure? Because what we say in that moment can really have a big impact in that vulnerable time. So the adversity, this is all about showing with empathy an interest in finding out in the first place about someone's adversity and trauma history, that this is important. It's really an essential part of health history for the reasons that I just shared, huge health impacts. The second part in the triads is distress. And so what is meant by that? Thinking about distress is a reminder to have curiosity about how is this person's adversity impacting them, and having a really open mind about that, because some people, of course, have already had a chance to process it, they may have gotten help with it, and they've really moved on, and they're perfectly healthy now. And if you think about all those health risks that I shared and the odds ratios, it does not imply that if you have ACEs, you will have one or more of these health conditions. It's just a risk. So distress is a way to consider, how do you feel this is impacting you? It's supportive inquiry, and it might be a chance to talk about health or emotions or behaviors. What is the impact? And what kind of answers we might get. You know, everybody understands stress eating, poor self-care, and those sorts of things, for example. Having had a violent relationship, we might be aware that, yeah, it's hard for me to trust. So some people already have a great awareness about that and are usually really engageable in a discussion about the impact, how they see it, not how we see it, how they see it. And then the third area is strengths. So many of us are familiar with strengths-based approach to our work, whether it's through the protective factors framework or another framework. The simple idea of making a positive assumption about each of our clients or patients that probably they already have a lot of supports and they already know a lot, they probably already know a lot about what helps them, is a much more effective way to approach this conversation than the other way around. People who approach the conversation from a deficit standpoint, where we find out about this problem and we think as professionals we have all the answers. So strengths is a much more empowering, collaborative way to think about it. And more specifically, the Triads framework has these specific questions embedded. Who helps you and what helps you? So just asking those questions communicate the perspective that we believe that every person has something that helps them. I just saw one of my well child checkups this week in Santa Rosa was the most adorable 9-year-old with lots of problems. She's a kid with a lot of challenges, a lot of problems. She's had a lot of trauma. She's in foster care. She's had a lot of therapy, and she's figured out a lot of stuff. And so I asked her this the other day, and she told me all about it. She knew exactly what helps her. She said, well, when I get stressed, I get my weighted blanket, and that helps me, and I get my Steffi. She has a Steffi who's like a huge support in her life, and if she's got her weighted blanket and her Steffi, she can get through quite a bit. So I was really impressed, you know, a 9-year-old to have that sort of self-awareness and know what's in her toolbox. But, you know, anyone at any age hopefully has a toolbox, and that's one of, I think, our jobs and the way we can help people is develop their strengths that they may already have a little bit of an idea about. So again, Triads framework, it promotes a very holistic approach to healthcare, and it helps patients understand how ACEs affect physical and emotional health, and it engages patients and clients as active partners in their own treatment. Okay, so what do we know about empathy as far as medical visits? In medical visits, communication has been studied quite a bit, and I'm kind of embarrassed for my profession because physicians, and I guess there aren't any other physicians on the call, I don't think, but we have a pretty poor track record in terms of interrupting patient stories. We usually give people on average 11 seconds to speak, and then we interrupt with a question or a redirection or something. So 11 seconds. What I'd like to do as a first exercise in terms of empathy skills is actually practice not interrupting as a first level skill. And so the opportunity here is to, we'll be in rooms, just in dyads, 2 people together, and each person will have the opportunity to speak for 5 minutes and listen for 5 minutes. And what I would ask the speaker to do, and you could take a moment now maybe to think about your own answers to this question of listening and being listened to. So the question is, or the challenge is, think of a time when you felt really heard and listened to. And who was it who was doing the listening? And what is it that you can remember them doing that helped? Now, it's possible that you may not be able to think of an example sort of in the moment like this, and that's okay. Or maybe you can't think of an example because you really haven't had that experience, which I think is sad if that's the case, but it's possible. So if you can't think of one, maybe think a little bit about and share for 5 minutes about what theoretically you would like to have someone do if you did have something important to share, or something where you felt a little bit vulnerable. What do you think would be helpful? And again, the challenge here and the opportunity is to take this as a chance to practice listening for 5 minutes. And then after each person has the 5 minutes, we'll take a few minutes when we come back to share a little bit about it. I'll introduce a Zoom tool that I just learned called the whiteboard, where you can type right into a shared screen, and we'll do that next. So I'd ask Erin if, well, before we go, does anybody have any questions about the exercise? Feel free to unmute. We're not too large of a group to just have people unmute and ask any questions before we go into the breakouts.
We do have one question in the chat.
Okay.
Pearl. It's not about the exercise.
Okay, what is the question? We can pause for a question, that's fine.
It says, at our clinic, we have started ACEs screening and ask strength-based questions. For example, what gives you hope and strength during hard times? Feedback from providers has been that asking these questions are somewhat awkward. Patients will ask, what do you mean? And are wondering what these questions have to do with a medical visit. Any suggestions on how to navigate or present these questions to patients?
Oh, that's great. I love the question, and thank you so much. So yes, I do have a response, and if others on the call have other responses, I would just welcome a conversation briefly about that. The way that I introduce a strength-based or resilience-oriented question is I will just pause from what I'm doing, and I'll say, we tend to focus on problems in health visits and what's wrong all the time, and really focus on problems. Why don't we just take a moment to talk about what's going well, what you appreciate about your family, what things that you do together to strengthen your family connections. So that's how I introduce it, very deliberately and transparently, that I'm shifting from what we usually do in that way. Do others have ideas or suggestions or experiences with other ways of reframing? Okay. All right, but thanks so much for the question. And I would really encourage you, the person who asked the question and others, to take this feedback, try it out, and try to find a way that works for you, to explain it to people. But I do think it's crucial and helpful to have strength-based and hope-oriented questions too. Okay, so we will, I see there is a hand raised. Brian, I can see that one.
Hey team, sorry for, my apologies for being late.
Oh no, it's fine. Welcome.
And I think, hey, how's everyone doing if I haven't met you? Brian Clement here from Dovetail Learning. Also, too, I think in service to the ACEs Aware dimension here, that the caring, buffering, nurturing relationship piece of the actual intervention, right? The screener is a dimension of the intervention itself, and just highlighting that connection is a place, and in our lexicon, where relational resilience gets built, so they can actually experience a dimension of, if we're going into toxic stress screener, sourcing that, right? I mean, there's a physiology around hope, gratitude. So I think from a medical side, right, we can lean into the buffering that connection can actually provide in that moment, though it might not be the solve.
Right, thank you so much. Yeah. I totally agree, yeah. And yeah, for sure, I mean, people are not used to it. This is kind of something new, so explaining it and offering that context, like Brian shared, I think makes a lot of sense. Okay, maybe we should go ahead and get the breakout started. We'll be back together in 10 minutes.
10 or 5, would you like? 5.
So it'll be 10 minutes because it'll be 5 minutes for each person.
Okay, great. And do we need a quick reminder, anybody, on what you're doing? I know we had a little discussion before.
So the question is here on the slide.
Oh, okay.
Think of a time when you felt heard, and who was it who was listening, and what is it that you remember that they did that helped?
Great. I will launch the rooms now, and if there's no one in your room, come on back to the main room, and we'll get you sorted out. Here we go.
Thank you.
We do have a few people who have requested not to be put in a breakout room, Dr. Pearl, so
okay, that's nice.
They're going to hang out in the main room, and I believe that includes Stephanie, Tonya.
Sure.
And let me see. Elsa, are you there? There may be people who are just listening and can't join.
Okay.
Let's see, Joseph, are you able to join your breakout room? Okay, I'm going to go ahead and move. Catherine, did you have no one in your room?
There were 3 of us in the room, and I didn't know if I wanted it to work that way.
You know, I'm going to go ahead and move you to a room where we have, I think, someone who can't get on. So I'm going to move you over to room 6 with Paige. Okay, if there's anybody else on right now who'd like to be in a breakout room, please let me know. All right, I think we're all right. Timer's going. Here we are. Oh, I can't hear you. Can't hear you, Dr. Pearl, you're muted.
Okay, sorry. Yeah, if you could send a message to the breakouts after 5 minutes to switch roles if they haven't.
Will do.
Thank you so much.
Hello.
Elsa?
Hi, I'm sorry, I had some technical difficulties.
Would you like to join a breakout room and practice?
Oh, yes.
Marissa, would you be willing to practice with Elsa? Awesome. I will assign you both to room 1. Hold, please.
I realized I was on mute, but yes, that sounds great.
Hello.
Okay, go ahead. You should be in. Oh, there she goes. Marissa, you go ahead and join. She's frozen. Let's see if she gets there. There she goes. Okay. All right. Everybody else is okay. Good. They're where they need to be. And they've got 2 minutes left till they switch. Do you know Dana Long, Deirdre? I follow her, I adore her, and I really want to come and have her speak at the Institute.
Oh, yeah. I used to work with Dana in Oakland, and we've been chatting sometimes about the ACEs Aware, so yeah.
Oh, man. I
could help you invite her if you want.
I might leverage and take you up on that offer.
Sure, yeah.
You know,
I think she probably gets a lot of requests, but
she does.
I'm sure she likes to speak. So
great. Just a couple months, we're already starting to think about 2022 when we might be able to physically be together again.
Oh, wouldn't that be great?
The wish list.
Yeah, nice.
Wish list of folks.
Does your institute ever do like professional retreats?
We have done multi-day conferences or like really tailored multi-day learning experiences for individual agencies. We haven't done like an overnight retreat. So day retreats, certainly.
Yeah, day retreat.
Yeah.
Nice.
We've done them for, actually, so St. Joseph Health has used our facilities quite often to run their own, but we've coordinated and executed them for school districts, for other health centers and health
great. Oh, maybe that's something we could think about. Is the institute located where the residential program is? How does that work?
Yeah, we have this huge campus, including.
I've been there for a talk. It's beautiful. Yeah.
So we also have an additional 60 acres across the street that is undeveloped, and there's a lot of work going on right now about.
Oh wow, is that right?
Mm-hmm.
Wow, I'd love to know more about that.
And now that we have our new CEO, hold on, I'm going to switch, who just started this week.
Oh,
a big portion of his projects.
Cool. You know, I had said I was going to use a whiteboard, but it may be that that's not an option.
Oh.
Which is okay. It was something that I had tried out, but I didn't think that it might be in some Zooms and not others. So that's also fine. It's not a problem.
You know, it's been a learning experience to figure out what functions are available in meeting format like this versus is not available, what's available in a webinar format. So for example, the reason why we had to change was because the original meeting didn't allow for breakout groups because webinar doesn't let you do that.
Right.
But let me poke around real quick. Whiteboard function on Zoom. Okay. So it says when you say click share screen, there should be an option that says.
Oh, whiteboard. That's right. Thank you. That's
sorry,
it.
I just stopped sharing. I might have accidentally.
I stopped sharing so I can try that. That's right. I forgot.
They have another 3.5 minutes, so you've got some time.
Oh, that's it. Thank you for finding that for me. I'll put that up and we can try it. So do you want to test it out, Erin? If you go to where it says annotate. Do you have something on your?
The annotation tool.
Or do you have something that says whiteboard now on your strip?
I do not have the annotate button. Polls, chat, share screen, pause, breakout rooms, reactions. I don't have annotate.
Oh, okay.
Maybe it's only you because you're the one sharing the screen.
Maybe it is. Okay. That's possible. I think I won't use it then. The idea was to have people, it's sort of like a Jamboard function, but I don't know. I had tested it. Maybe it's a different Zoom version. As a participant, maybe you can't. What if you look in more? Do you have annotate there?
Mute video security, poll, chat, share screen, pause, breakout rooms. I don't even have a more button at this moment.
Oh, okay. We'll just skip that. That's fine. It was just kind of an idea.
Let's see. Trying to see if we could quickly make a Jamboard. All right, we've got another 1 minute and 20 seconds.
Okay.
Would you like me to make a Jamboard real quick?
Yeah, if you can, and then you could put the link into the chat. We can try it.
So if I put this in the chat, let's test it right now.
I'll stop screen sharing.
All right, well, I'm going to send this just to you, Deirdre, and you tell me.
Okay.
I just put it in the chat and I'll share my screen. And you tell me.
Oh, well, it says that I need access. Yeah.
It may not work this time, but
no, let's skip it for now. That's okay.
Okay. Let me go ahead and stop sharing. Okay, closing the breakout rooms. People should be coming back in.
Okay, great. Thank you. Okay. Well, welcome back, everybody. I'd love to take just a couple of minutes to hear anything that you might like to share about the experience, anything that you noticed or learned or have questions about. And I had promised you something called the whiteboard, but we had some technical issues with it. So instead, we'll just go ahead and talk for a few minutes. Very old school. We'll just talk.
Deirdre, there are 4 folks who still, they have 11 seconds to come back.
So. Okay, sure. Thank you. You can let me know when everybody's back.
3, 2, 1, and there were. You doodled on the whiteboard. The doodle came up on my screen, FYI.
Okay. All right. Well, maybe now we have everybody back. Welcome back. I hope that that was a useful practice time. And I'd mentioned the whiteboard. We had a technical glitch with that. I apologize, but we'll just have kind of a couple minutes to have a conversation. Please feel free. Go ahead and unmute. And we can just share anything that you noticed, anything that was maybe surprising, anything you learned, any questions related to the 5 minutes of listening. So please go ahead and pipe up. You don't even have to raise your hand. Go ahead and unmute, and let's just hear from a few people.
I was just going to say there's a nice intimacy that you get that you don't get when you're in a group, when you're one-on-one and you're talking with somebody and just asking questions or hearing them talk for a couple of minutes, and you just feel like you get a chance to know them a little bit more than you possibly could in 20 minutes in a group setting.
Nice. Thank you. Any other?
For me, Deirdre, it was just taking that pause to be open allowed me to really sit and I don't know how to explain it. It was almost like Mary, I wanted to say, it's like I'm virtually hugging and listening. I'm just so open and receiving everything that you're sharing. And it just, I wanted to hug you afterwards, and just, there was that intimacy, that connection.
Right. And it happened in 5 minutes, right? Doesn't have to take a lot of time. Other thoughts? Okay. All right. Well, thank you so much for participating and for your reflections. I really appreciate it. I'm going to share next more about how to communicate empathy to others, in addition to not interrupting, to build on that. Some of us may be familiar with the work of Brené Brown. She, in this little cartoon, gives a great explanation of communicating empathy as different from sympathy. And it's a 3-minute cartoon. And so I'm going to share that now. Okay, give me just a minute here. Let's see. Okay, I thought I had it as a, has a link. I'm sorry about that.
Deirdre, is it okay if I just chime in on that experience?
Of course, go right ahead.
A little bit more. One, it was great to meet Rachel.
Great.
And I think when I was listening with her, I was struck by, in our skill set, we are resilient. We call that a heartfelt listening. And as the sort of silos between medical side and behavioral health side, the thinning of the models, that we're actually providing something. In that notion that we have to do the medical, like why you're cutting people off is to, historically in the medical model to do something, versus the listening is a gift, and I think that's what I experienced when I was remembering my version of the story. Is my dad listening to me allowed me to get through the dimensions that were inside me, and so there is a give there. Reframing is I'm receiving, but it's actually a presencing and gift. And so I was made aware of that through that exercise. So I appreciate a little pause there so I could reflect a little more deeply.
Thank you so much, Brian. That's great to hear. It's very sweet memory. Thank you. Okay, and I apologize for
what could happen is making nothing happen in your life. If so, I want to
technical challenges. Here we go.
How many of you are blamers? How many of you, when something goes wrong...
Go back one, Deirdre. I think it's just the...
What did I do?
There you go. There it is.
You sometimes find the fear of what could happen is making nothing happen in your life. If so, I want to come down...
No worries. There it is.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm gonna climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Okay, so just to review her main points in the next slide here. Points about empathy. It fuels connection. It's taking the other's perspective. It's staying out of. It's recognizing emotions, feeling with people. I do agree with her. It's a sacred space. It never starts with at least. And what makes something better is connection. So this is an empathic communication exercise from my colleague Elizabeth Morrison, who's a consultant and has many years of doing empathy training. So she shared some of these slides with me. 3 skills that we'll see in the next couple slides demonstrated very nicely and simply. An empathic reflection, what does that look like? Affirming strengths, what's an example of how do we do that? And the skill of normalizing, very important. Before we show those, just a little bit more on what empathy is not. So empathy is not about giving advice. It's not about being defensive. It's never about minimizing someone's concerns, even if it seems small compared to someone else's or your own. And it should never be dismissive. I know this kind of goes without saying, but just to call out some examples of what would not be an empathic response. And now here's the examples of the 3 skills. Is anyone brave enough to volunteer to read? You don't have to make it up, just to read. Do the little role play with me. I'll be the patient and you can be the responder demonstrating these skills. Any volunteers, please? Just one. It's really easy. You just have to read it.
Sure, I'll do that with you.
Thank you so much. That's great. All right, here's the first one. So again, I'm the patient or the client. And what I'm going to say in all 3 versions is the same. So here we go. I'm just so overwhelmed. Like, I just can't get a break these days. I am so worried about my son.
You are so overwhelmed. It really sounds like you're worried about your son.
Yes. Excellent. Thank you. All right. Next one. Affirming strengths or someone's good intentions is another way of doing this. I am just so overwhelmed. Like, I can't get a break these days. I'm so worried about my son.
I can hear how much you love your son and how much you want to help him.
Thank you. It really feels better just in the role play. It's like, oh my God, if people actually said things like that, it would be nice, right? And the normalizing example is next. So I am just so overwhelmed. Like, I can't get a break these days. I'm just so worried about my son.
Yeah, many people are feeling overwhelmed right now and worried about their loved ones.
Perfect. Thank you so much. That was a great demo. And what I really like about Elizabeth's examples are they're so simple, right? Again, it doesn't take a lot of time, but it really communicates that you're there with the person. So empathy, partly about what we should say, what we shouldn't say, and what about the nonverbal part of empathy? I look at this image. What I see is a clinician sitting on the same level with the patient. I see her away from her computer and looking at the patient. She looks engaged. She looks open. She looks like there's a nice relationship going on. And she'll probably be a lot more receptive to whatever guidance or recommendations the clinician makes. Breaking down empathy into more specific nonverbal skills. This framework was created by Helen Reese, psychiatrist, where E stands for eye contact. And we know this, right? But it's sometimes nice to have a mnemonic, a way to remember things. M, the muscles of facial expression. If we furrow our brow, that communicates judgment. If we're open with our face, it helps. Our posture, right? If we're actually our posture is open and towards the patient. That's also a nice way of showing we're there with them. Our affect, do we sound rushed and stressed, or do we sound, or not sound, but what are we communicating about our affect or our mood by our body? Using our tone of voice. The H is to remember to hear the whole patient, and Y is then your response. Okay, so we have another possible, let's see. I might actually go a little bit out of order and possibly save the next practice for later, perhaps. And I'll go to this question. So because I've been involved with the ACEs screening for many years now, one question that I'm very commonly asked is, isn't screening for ACEs re-traumatizing? It's a great question. And I mean, the reality is, the real answer is that it can be, right? It all depends how we do it. If we sit in judgment and reinforce a person's sense of shame and self-blame, well, yeah, that deepens the trauma, can make it worse. But that's what, we don't have to do it that way. And if we do it in this empathic way, then it can actually be a healing experience. And the way that I think about it in that way, in terms of re-traumatizing, the single most important part of that, from my perspective, is this idea of control. So an inherent part of trauma and abuse is the loss of control, right? It's overwhelming, it's uncontrollable, it's unpredictable, and it really shatters a normal, healthy expectation of safety and predictability in the world. And it creates shame and guilt almost universally. So how can empathic ACEs screening and response reverse that? So this is how it can work. When we do a screen, we really need to explain the rationale so they can understand the reason. We always want to ask permission. Again, the control part of it. They can say no. In my experience, it's rare that someone says no, but at least if they say no, they're asserting their control. Maybe they'll say yes next time, and that's usually what we find. By asking them to explain their distress, it helps them, right? Have that understanding, and sharing with them that being dysregulated, that's a normal response and a consequence of trauma and ACEs. And then most importantly, when we do those positive things, like engaging about their strengths and helping them build on the strengths, conveying that sense of hope, it's very empowering. And that's how ACEs can be, screening and response can be healing and absolutely not re-traumatizing. I have another short video clip to share. I hope these are feeling useful examples and real world examples. This is a family I've worked with for years in the clinic. And I think what it demonstrates in just a couple minutes is how that experience can be healing and not re-traumatizing. This is a family with very high ACEs. So the speaker in the video is the mother, Clara, on the right there. She's given permission to use this video in educational functions. She shares that she's overcome substance use disorder over a lot of work and time and getting a lot of help. And after losing her children with CPS involved and all, she was able to get them back. And her comment here is how helpful it's been that her son has been able to open up to me at our visits. And then she describes a little bit about her own healing. I feel like we'd all be better off in medicine and human services if we called out positive examples more often. So hopefully this is a good positive example to share.
She knows everything I know about my son. And I get that comfortable feeling where I could actually tell her, not hold anything back or hide anything from her. I feel that she needs to know. She opens up something in my son that he's a whole different child around her. I mean, his feelings come out. He cries to her. You know what I mean? It's like he's not like that with anybody else. Now I'm clean and sober. I quit smoking cigarettes. I don't drink. I volunteer. I drive my kids to schools. I get up early. I go to bed early. I cook dinners. It's totally different from where I was 7 years ago, living out of motel rooms, you know, being there physically but not mentally for my children. I'm really lucky and happy that we ended up where we ended up.
So there's the triads framework. I thought I'd bring that back into view and into mind as far as focusing on the triad of adversity, distress, and strengths. And what I'll shift to now is what is a very concrete script and example for what you might say or practice saying in response to an ACE screen. So the first part, in my opinion, should be an acknowledgement, thanking them for completing the questionnaire. It is a lot of personal information, and if they complete it, that should really be acknowledged. And I think in any conversation, whether it's a business meeting, a family event, a patient interaction, working with a client, always starting with gratitude sets the stage for a more productive interaction, whatever the goals and agenda might be. So I try to make this a practice in general in my work and my life, and definitely working with patients. So thank them for anything. Thanks for coming in today. Thanks for completing the questionnaire. Gets things going. Second, safety check. We're talking about child abuse and intimate partner violence in some of these situations. So really everything else on our agenda has to be secondary to making sure that the current home situation is safe. So we really need to ask about that. We shouldn't be assuming anything. And it can be as simple as saying, how are things at home now? Are there any times that you're feeling unsafe? And then the third part of this script is that triads question about the strengths. And you can say it, in different ways. One way I like to ask is, when life is hard, what helps you? Who helps you through it? Another way to ask is, what keeps you going? I learned that really golden question from a physiatrist. My mother was having tremendous back pain, and she'd been to a lot of different people. Someone said, oh, you've got to take her to this doctor. He's just a miracle when it comes to back pain. He helps, actually a colleague said, this guy helps patients who have suffered for years and no one else can help. So that's quite an endorsement, right? I said, okay, I'll go. I had to bring her to San Francisco. Went to this doctor, and he does a lot of hands-on work with pain and backs. But he's the kind of doctor who does the mind-body work simultaneously, which is just beautiful. So anyway, he took the history, he did the exam, and he's starting to work on her back and loosen up some areas. And so while his hands are on her and he gets her talking about her life and some of the hardships that she's faced recently, he used that question. He said, what keeps you going? It's such a great way of acknowledging, like, I really get it. This sounds hard. It's a strengths-based, right? Like, I'm assuming that you know something or you have some help because here you are today, right? So what keeps you going? Anyway, she did experience a lot of relief. So I just really like that question. So I'm including that here. I think what we'll do is now practice in the breakout rooms exactly those three questions. So for this next breakout, which will have 10 minutes and then come back together for the last couple minutes together, I'd really like for you to try this triad script. So these 3 questions, where it's, not 3 questions, but these 3 statements and questions. Thank you, safety check, and when things are hard, what helps you and who helps you. So we'll have one person say these things, and the other person maybe take the opportunity to think a little bit about, what helps me when things are hard for me. Like, what are my go-tos? What's my security blanket, or my dog, or my stuffy, or my best friend, or my therapist? Like, what is that thing or that person in my life? Well, who's in my toolbox? So this is a chance to both practice the script and also do a little reflecting and sharing about what are those things in my toolbox. And we'll take 5 minutes each again, and then come back. Any questions before we do that?
There is a question in the chat around conversations, talking with clients about this via telehealth.
Mm-hmm. Yeah, great question. And yeah, it can be done. I mean, it's really, I think, up to each person and each practice or organization to make those decisions about telehealth. I mean, Santa Rosa, we've been 80% telehealth all year. We're starting to shift the balance a little bit, but we decided some of our practitioners and some of our clinics have not done these very sensitive conversations via telehealth, and some have. I mean, there's certainly issues to assess as far as safety and privacy. Sometimes people really are living with a lot of people, and there is no privacy at home, so it might not be possible. So I don't have kind of an answer, and it's not a one-size-fits-all, but I will say that in some cases, I have had these sensitive conversations when it's felt possible and appropriate, and it's gone actually really well. So yeah, so that's my response there. Anything else before we do the practicing?
Just a quick note to let folks know that some folks have jumped on and jumped off, so you may have a new partner, and that is A-okay.
Okay. And actually what I might do, just given the time, is we might shorten a little bit rather than a 10-minute. Maybe we'll just take 7 minutes, and then we'll have a little more time to conclude together.
Great.
All right.
All right, then I'm going to go ahead and launch you all.
Okay.
Let's see. So I'm going to go ahead and Stephanie and Tonya and Joseph are still not. Okay. Marissa, I'm keeping you out just because we have a exact number. Just so you know, Deirdre, Marissa is our grants and foundation relations guru at Henna. So,
oh, great.
Feel okay keeping her out.
Thanks for attending today. Nice to meet you.
Oh, you're muted, gal.
I don't even have a baby in the background right now. I don't know what's going on, why I'm staying muted, but I'm really, really enjoying it. So thank you so much. I'm grateful. I actually looked up the other day the difference between empathy and sympathy, just because I wanted to remind myself. So seeing that video, I was like, oh, this is great.
Oh, wow. Perfect. Good. I'm glad to hear that. Wonderful. Yeah.
And actually, I have a question, if you don't mind.
Sure. Oh, no. Of course. Please.
Thank you. I was just thinking, I think it's probably less likely in a professional setting, but I think some of us, I know I'm guilty of it, when you are talking with somebody and you're trying to listen, you find you want to share your personal stories too. So you're listening, but you want to empathize, but unfortunately that comes out as sharing, oh, I've been through that too, or oh, I had a similar situation. And so I don't know if there's a way to train yourself to, or just being cognizant of the fact that that's not necessarily the way to go.
Yeah, it's a great question. And I think, you know, in my experience, that's extremely common. That is kind of like a go-to, oh, same thing. And then the conversation is all about them.
Right.
So I think that there can be a helpful therapeutic role of some amount of self-disclosure sometimes if done in a very specific way and really limited and doesn't take the conversation to be all about me. Like there's that joke, let's see. Well, I've been talking enough about me. What do you think about me? Like some people just need to be in the spotlight, like right. No matter what. But if our goal is to be supportive, it's usually not very helpful. Yeah. But I think it can be a little bit sometimes in terms of the normalizing. Mm-hmm. I think that there can be a role of that. I think that, sometimes depending on the situation of the family, I might say, I've had some ACEs just to say, like, this isn't like just your problem. It's really common. And I've had some of these myself, and I won't go into it. I don't share details, but, I might say that just something, sometimes that kind of can make it feel like a more human level setting interaction. So I don't think there's anything wrong with that. And I think it can be helpful, but the risk is that suddenly it's all about me. Yeah.
Right. So it's striking that balance from the sound of it.
Right. Yeah. So generally I would say I would probably avoid it, but if at all, just do it a little bit. Yeah.
Yeah. Interesting. Thank you.
Yeah, sure.
By the way, Deirdre, I just had an email pop up this morning. So our director of research at Hannah Institute, Dr. Daniela Dominguez, she also runs she's the assistant professor and she's the research, she's the MFT program coordinator for USF's Marriage and Family Therapy program in Santa Rosa for their satellite site. The Healthcare Foundation of Northern Sonoma County is offering 100% scholarships for bilingual, bicultural students in Sonoma County who want to pursue their MFT.
Wow.
So I'm going to forward you just this email. I know this is...
That's exciting.
If you know anyone or there's folks at...
Yeah, thank you. That's great. We need a lot of that workforce development help. It is so hard to find bilingual, bicultural mental health, behavioral health staff.
Okay, they have 1.5 minutes left.
Okay, great.
They'll start to come back in. I give them a 1 minute heads up, but a lot of folks jump back in.
Okay, sounds good.
All right, 1 minute left. We'll go ahead and close out all the rooms.
Okay.
Oh, so they get a 60-second warning to close out the rooms. Okay.
Oh, okay.
Be a minute or two over, but that's all right. I'm going to drop the eval in the chat now. Just in case folks have to skedaddle. They have it before they go. Yeah, I think we've got everybody back.
Okay, wonderful. Well, we just have a couple minutes before our time is over. And so I hope that this has been helpful for you. I welcome your feedback. I'm sure you'll get a survey afterwards. And just before we end, I feel like it's really important just to make sure to include this idea of preventing secondary traumatic stress. And what is that? When we hear a trauma story, that can be traumatizing for us. And that's where self-care and self-compassion as part of it is crucial. Otherwise, we really put ourselves in jeopardy of burnout. So I'd just like to mention that and encourage you all to consider what self-compassion could look like. Whatever your practices are now, I would just leave you with the thought of how might you enhance that, give a little more time to refuge for yourself, something centering, healthy time, space, just to have your human experience. Work is very hard for everyone these days. And we're not through this pandemic. There's so many challenges. So I just leave you with a thought of how might we enhance our self-compassion, and then share these resources with you that are all very helpful. And Erin had asked about sharing the presentation. I'm totally fine to share it, disseminate it, spread it, invite me, whatever might be useful for you or your organization. Thank you so much for participating. I really appreciate all the engagement, and I've really enjoyed it. So, and thanks to Erin and the Hannah Institute.
Great, thank you so much, Dr. Pearl. I've shared the evaluation in the chat. Please, please, please take a moment. It's not too long to fill it out. This helps us report back to the state and keep getting more funding for this kind of work. I've also shared information about our next upcoming training activity, which is a 2-day event, maternal mental health, addressing the impact of ACEs, toxic stress, and intergenerational trauma. That'll be led by Allison Murphy and Jennifer Silverstein, who run a universal pre- and postpartum depression and a mood disorder program here in Sonoma County, and they have been incorporating ACEs screening findings in their treatment programs. So we're really excited about this activity. And if you have any questions, I'll go ahead and get information, my email out to all of you. We'll send a follow-up email as well with the recording and the slides in the next few days. CEUs for addiction counselors. Joseph, I see your question there. We, the Hannah Institute, can offer CEUs under our Redwood Empire California Association of Marriage and Family Therapists. That includes MFTs, LCSW, school counselors, and one other one. I'll check for you, Joseph, about CEUs for addiction counseling. Was that for this training or for the next one on maternal mental health? I don't know if Joseph can answer or not. That's right, I don't know. Otherwise, thank you all so much. We ran a few minutes over as always. Please check out NorCalAcesAware.org. I'll be on for another few minutes, but it was wonderful to have you all with us today.